about those tumors as a group. This is the most common group of tumors, maybe because the epithelium, it's quickly renewing tissue, really susceptible to any kind of environmental injuries. And also because the epithelium covers the whole body and the body cavities. So it really comes into contact with all the carcinogens that we come across in the environment. That keeps popping up, all those. Okay. So we'll start with the first slide, which is called carcinoma planocellulare keratodes in your schedule, or this is the squamous cell carcinoma. Like in every other slide, first we have to identify the organ that we're looking at. So here you have a nice view of it. So what can you say about the organ here? This is the lining squamous epithelium at the top. We have also sweat glands. You can see them here in the dermis. And sebaceous glands. So what would be your guess about the organ here? Anyone?
Maybe skin.
It's skin. Okay, so this is the first step. So you identify the skin because we have the squamous epithelium, the dermis, the sweat glands, the sebaceous glands, those the light appearing ones. And this one also. Up to here, everything looks normal. So we continue to look through the slide. And here we reach a space where everything changes. Okay, maybe we can stop here. What do we see here and how do we explain that? We see nests of tumor cells, this one here and this one and this one. I hope you see the arrow because I'm circling all the tumor nests. They are different size, different shape. And how do we know those are tumorous nests? They invade. Here they invade the underlying tissue.
Professor can't see the arrow.
And now? You still don't see it?
No, still not.
Mm-hmm.
No, Professor.
Okay, let me call for help with that arrow and then we'll continue. Okay, apparently I'm not going to be able to show you those things with the arrow. So I'm going to just try to get a closer view of what I'm explaining. So all those nests that you see here with cells with ample pink cytoplasm, they represent the tumorous nests. And as we said, they invade the underlying tissue. They're composed of malignant squamous cells that retain their ability to produce keratin. And here in the center, you see those pink solid whirly masses that actually represent the keratin. And that retention of the ability to produce keratin is really typical for the well-differentiated squamous cell carcinoma. Those are more keratin pearls here. There are some right in the center. They look like laminated, whirly pink masses, and this is the keratin. So this is what is expected from you to explain about this tumor. That you have nests of malignant squamous cells that invade the underlying tissue and that retain their ability to produce keratin. The next thing is they can ask you for what organs is typical, where is typical to see those tumors. Apparently skin is one organ where you can see that tumor. For what other organs can we expect that tumor to be present? Just think about what other organs are lined with squamous epithelium. Of course, the oral cavity, the tonsils, esophagus. What else? Vagina and exocervix is also lined by squamous epithelium. So all those are the places where we can see that tumor. Can we see a squamous cell carcinoma in the bronchus? Anyone? Is it possible to see it in the bronchus? And if yes, why? Yes, it's possible. Normally, the lining epithelium in the bronchus is pseudostratified columnar epithelium. But in the case of heavy smokers or chronic inflammatory diseases of the lungs, pseudostratified columnar epithelium can turn into a squamous. This is a process called metaplasia. So on the ground of that metaplasia, we can see squamous cell carcinoma arising in the bronchus. Okay, about the macroscopic view, the gross view of the tumor, what could be the major presentation of that tumor? Okay, it usually starts here from the squamous epithelium. The tumor cells take up the whole thickness of that squamous epithelium. This is the non-invasive phase of the tumor, when the tumor still didn't breach the basement membrane and didn't invade the dermis. This is called carcinoma in situ. And usually in that phase, the gross view of the tumor is plaque. It's a plaque-like appearance. Then when the tumor starts to invade the underlying dermis, it starts to look as an ulcerative lesion. So this is important about the gross view of that tumor. What about the metastasis? Is it possible to give any metastasis? Yes.
Yes.
Yes, it can give metastasis not only in the lymph nodes, but also hematogenous metastasis in other organs, internal organs. This is important because the next tumor that we're going to see usually doesn't give any metastasis. So you should differentiate between both of them. So this is your squamous cell carcinoma or carcinoma planocellulare keratodes, as it's listed in your schedule. Both names are right. You can use both names. Just one of them it's Latin, and the other one, squamous cell carcinoma, is the one that you're going to see in the books more often. We continue with the next slide. Again, we should do our organ diagnosis. Again, here we see squamous epithelium at the top, that dark purple line, and in the underlying dermis, we see all the sebaceous glands that we know from the previous slide. So again, we say skin. We keep looking further. And here we see something that doesn't seem right. In the dermis, you see all those bluish nests of tumor cells that are different size, different shape, and they invade the dermis. This is how we know they're malignant, because of the different size, different shape, and the invasion, the spreading in the dermis. This is the basal cell carcinoma of the skin. So here the important point to know is where is the normal location of that tumor. It usually affects only the skin, no internal organs. And mostly those are the sun-exposed parts of the skin. On the first place is the face. About the metastasis, that tumor usually doesn't give any metastasis. This is the difference with the squamous, one of the differences with the squamous cell carcinoma, the previous one. It doesn't give metastasis. Another thing, the gross view of the tumor. How does it look macroscopically? It can have a really different macroscopic pictures. So it's a great mimicker. It can look like an unhealing ulcer, the so-called ulcus rodens, if you read about it in some of your books. Every ulcer on the face that doesn't heal for more than 2 weeks is really suspicious for basal cell carcinoma. So you better make a biopsy, like incisional biopsy, to prove the tumor, but don't keep treating the tumor with corticosteroid or other creams. Just take a biopsy because it's really suspicious if that ulcer persists for more than 2 weeks. Besides ulcerative lesion, it can look like a nodular lesion. It can look like a pigmented lesion. It can look like eczema or even like a cicatrix. So it's a great mimicker. And for every one of those lesions that we've mentioned, if it persists on the face for more than 2 weeks, suspect the basal cell carcinoma and take a biopsy. Because you will say, okay, if it doesn't give any metastasis, why is it so important to diagnose it early? Because it has a local invasive growth. It grows bigger and bigger. It can invade the deeper tissues, even the cartilage of the nose, the underlying bone. So it's really important to treat that disease before it disfigures the patient. Okay, on the base of histology, what is important to say about that tumor? First, you have nests of more purplish, more basaloid appearing cells. This is in contrast with the previous slide where you had pink appearing cells with ample pink cytoplasm. Here they look purple because the basal cell, this is the histologic view of the basal cells of the epidermis. This is the basal cell carcinoma. On the second place, you have those peripherally placed perpendicular cells that surround those nests. So the nests...
I'm sorry, Professor, but I can't see the screen. Like, I can't see the slide.
This is for all of you. All of you cannot see the slide, or?
I can see the slide.
I can see the slide.
Okay, some of you can see it.
Okay, now I see it. Okay, perfect.
Okay, now I don't see it anymore.
Mm-hmm. Maybe there is something wrong with the connection from time to time. So maybe that's why. Can you see it now, all of you?
Yes.
Mm-hmm. Okay. Okay. Here in the center of that field, we have one of those nests, which is really well delineated due to that perpendicular arrangement of the cells at the periphery. This is the second criteria, histologic criteria. That palisading or perpendicular arrangement of the cells at the periphery of those nests. And the third criteria is the detachment of the stroma from those nests. You can see that in the lower right quadrant of that nest. You see that detachment, like empty space between the nest, the tumor nest, and the surrounding stroma. This is another typical criteria, histologic criteria for the basal cell carcinoma. So when you got all of those, you're done with your diagnosis. So bluish tumor nests that invade the dermis, peripheral palisading of the cells, and that specific detachment of the stroma from the tumor nests. Those are all the criteria that you need to get to the diagnosis. This is a cystic space in the middle of one of the tumor nests.
Professor, can't see the slide. Is there any possibility, can you record it so we can see if we are missing anything later?
No, with that platform, I don't think there is such possibility. If some of you don't see most of the presentation, that they can join the other group, because we will split all the students into two fractions, so you can join the other fraction if you miss most of that presentation.
If not, I'm sure somebody can record it.
Mm-hmm.
Like one of us can record it, screen capture it.
Okay, that would be good also.
They might already be doing it.
Mm-hmm. Okay, so those are the most important things about that slide. So you should know where is the location of that tumor, what is the biologic behavior, local invasive growth, but no metastatic potential. And you should know the histologic criteria for the diagnosis. The bluish tumor nests located in the dermis, the peripheral palisading of the cells, and that detachment, that empty space between the tumor nests and the stroma, that are really helpful with the diagnosis. And of course, be aware of the gross forms of that tumor and how to recognize it. Okay, so this was the basal cell carcinoma, or carcinoma basocellulare. We move to the third slide from the malignant epithelial tumors. And again, we will start with the recognition of the normal organ. Here, stomach, yes. Here we see the mucosa with the glands, the stomach type glands, the submucosa, and that a thick pink layer, which is muscularis propria, and the subserosal fat tissue that comes after that. So the typical 4 layers that we can see along the stomach, small and large intestine. So once you got the diagnosis stomach, then we should look for the pathology. We keep moving. So we get to that area where we see that something is not right, that something doesn't seem like in the normal mucosa, in the normal wall of the stomach. And how do we describe those changes? Here we have malignant glands that invade the organ. Again, how do we know those glands are malignant?
Of the different shape and size, and that
Yes.
they invade the underlying tissue.
Yes. Just compare them with the normal stomach glands at the top right. They're almost the same shape, the same size. They look really organized. And here, coming down to the left of the slides, we see glands that are really different size, different shape. They are disfigured. We see cellular atypia also. Why cellular atypia? Because the nuclei of those cells look really big. So we have increased nuclear to cytoplasmic ratio. We have hyperchromatic nuclei also. And at some places, we may even see mitosis. So this is our cellular atypia that is present. And here we see that all those malignant glands invade the muscularis propria. This is the thick, solid pink tissue in the right quadrant of the picture. So we are sure that we're dealing with adenocarcinoma ventriculi. So this is the name of your slide, adenocarcinoma ventriculi, because we are sure we're dealing with malignant epithelial tumor of the stomach, the most common one of the stomach. Actually, we have two main histologic variants of the stomach carcinoma. In this case, when the tumor cells are making glandular structures, this is called intestinal type adenocarcinoma. And what if the tumor cells doesn't make any glandular structures and they just diffusely infiltrate the wall of the stomach without making any glands? This is the so-called diffuse variant of stomach carcinoma. So we have two major variants, intestinal type, that is making glands, malignant glands, and diffuse type, where the tumor cells invade freely, disorganizedly, without making any glandular structures. Those two types of stomach carcinoma have different predisposing factors and have different gross appearance of the tumor. First, let's say something about the intestinal type, the one that we're looking at right now. It usually affects more older individuals, 50 and older. And usually the predisposing condition is the chronic gastritis caused by Helicobacter pylori that causes intestinal metaplasia of the mucosa, then dysplasia that turns into a malignant tumor, into adenocarcinoma. This is the sequence of events. And the most common gross view of that tumor is an ulcerative lesion, an ulcer. What about the diffusely infiltrative, the diffuse variant of stomach carcinoma? That one usually affects younger individuals, 50 and less than 50. It usually comes on almost normal mucosa, normal stomach. And what is the gross view of that tumor? If we're looking at the removed stomach of the patient with diffuse stomach carcinoma, how does it look? Usually, it looks like a thick, rigid wall of the stomach, which is called linitis plastica. So the gross view of the diffuse stomach carcinoma is called linitis plastica because the stomach wall, the invaded stomach wall, looks thickened and rigid, hard, and this is called linitis plastica. What about the metastatic potential of that tumor? It gives lymphogenous metastasis to the regional lymph nodes, mostly the perigastric lymph nodes, or it can give also hematogenous metastasis. And what are the organs where we can see those metastases?
Liver, lungs.
Mm-hmm. Yes. Yes, liver, lungs mostly. Mm-hmm. And there are some specific metastases, and you should know the names of those. You're going to need them in the fourth course in your future practice. This is the Virchow gland. What is Virchow gland? It's a metastatic left supraclavicular lymph node. When it's metastatic, it's enlarged, it's hard, and we call it Virchow gland. There is another specific metastasis in the soft tissue around the navel. It is called Mary Joseph's metastasis. And one specific metastasis that we can see in both ovaries from the stomach carcinoma. This is called Krukenberg tumor. Bilateral ovarian metastasis from stomach carcinoma is called Krukenberg tumor. So this is what you need to know about the adenocarcinoma of the stomach and what you just explained over the slide. So you should recognize that it is stomach, just looking at the normal mucosa. And then you should be able to point where starts the adenocarcinoma and why do you think it's an adenocarcinoma? Because it's invasive, because it has glands with different size, different shape, with nuclear pleomorphism. And everything else that you're going to be talking about adenocarcinoma ventriculi is a theory. Okay, so we move to the next slide. It is called carcinoma gelatinosum. Or mucinous carcinoma, it's another name of that tumor. Okay, we can stop here. Why mucinous carcinoma? Because more than 50% of the whole tumor mass represents mucin or gelatinous material that is produced by the tumor cells. All those grayish acellular substances that you see here in the field, they represent mucin. And here in the center of the field, you see one strip of epithelium. And those are the cells that produce that mucin. It's a variant of the conventional adenocarcinoma. Here in the center, we see another dark purple strip of malignant epithelium producing that mucin. And here at the bottom, you see some fat tissue that is invaded by the tumor. Again, here at the bottom, some strips of malignant epithelium, producing all those grayish masses above that represent the mucin. It's really an aggressive tumor because the mucin is an aggressive substance. It's a variant of the conventional adenocarcinoma, and where we can see that tumor everywhere in the gastrointestinal tract. We can see it in the stomach, in the small, in the large intestine. We can see it in the pancreas, in the biliary tract, the malignant neoplasms of the biliary tract, in the lungs also. And that could be also a subtype of the breast carcinoma, mucinous carcinoma of the breast. But just the difference is that in the breast, that tumor is associated with the better prognosis. It's not so aggressive like the one that we see in the gastrointestinal tract. So usually by the time of the diagnosis, that tumor has invaded most of the wall of the stomach or the intestine. And usually we find metastasis in the regional lymph nodes. So it's an aggressive tumor. And here we see some tumor cells floating into that mucin. Some of them can contain mucin in their cytoplasms, which seems empty, and the nucleus seems pushed towards the nuclear membrane. Those are called signet ring cells. So we could deal either with extracellular mucin, like all those spaces with mucin surrounding the cells, or that could be an intracellular mucin, like the one that we see in the cytoplasm of the tumor cells, pushing the nucleus aside, and that's why we call them signet ring cells. So this is about the mucinous carcinoma or carcinoma gelatinosum, like it's said in your slides. So you look for those gray appearing masses that represent the mucin, and you look for all those fragments or strips with malignant epithelium. Here you cannot say what is the organ because we have no preserved mucosa of the organ. So we are not able to say what is the primary organ affected by that mucinous carcinoma. Another important thing that you should remember about that tumor is that in the mucinous carcinoma, the tumor cells may produce procoagulant substances that actually can turn on the coagulation cascade within the blood vessels and lead to thromboemboli in the blood vessels. And those thromboemboli, called migratory thromboemboli, because they come and go. This is a specific type of paraneoplastic syndrome, and it is called Trousseau syndrome. It's described for the first time in the pancreatic carcinoma. So they can produce procoagulant substances that can lead to thromboembolic events into the blood vessels. And this is called syndrome of Trousseau. Okay, this is about carcinoma gelatinosum or mucinous carcinoma. And we move to the last slide from the first part of epithelial tumors. This is adenocarcinoma ventriculi, adenocarcinoma uteri. We've seen ventriculi. First, how are we going to make our organ diagnosis? We see here a really thick muscular layer. And such thick muscular layer with that whirly pattern of the smooth muscle cells, it's typical for the myometrium. And also towards the serosa that covers that myometrium, we will see such thick-walled blood vessels. We see two of them here in the center of that field. We see a whole group here of such thick-walled blood vessels. And that dark purple material in the wall of the one of the blood vessels on the right is calcifications in the media of that blood vessels is really typical about the blood vessels of the myometrium. So we got that thick muscular layer, and we got those thick-walled blood vessels toward the periphery, toward the serosa. So this is a hint that we're looking at the myometrium. And one of the few slides that you have from the uterus is adenocarcinoma uteri. And here we get to the malignant epithelial structures that invade the myometrium. Do you remember what other slide did you have from endometrium and myometrium last year in the first semester? What other pathology of the endometrium did you see last year? That was hyperplasia of the endometrium. Hyperplasia. But the hyperplasia, what is typical for it? The glands in the hyperplasia are more orderly placed and they don't invade the myometrium. Here we see glands that really has, again, different size, different shape. And they are like back to back, really tightly packed glands with almost no intervening stroma. This is really typical for adenocarcinoma. So you see those uneven glandular structures that are really tightly packed with almost no stroma. Again, we see the cellular atypia. Those nuclei are really big, so we are dealing with increased nuclear to cytoplasmic ratio. Some of them are dark, hyperchromatic. And here we see how those malignant glands just are entering, they invade into the underlying myometrium. So here we can say we're dealing with adenocarcinoma uteri, not hyperplasia, it's adenocarcinoma because all those histologic features that we've mentioned. This is the so-called endometrioid adenocarcinoma of the uterus, because we have also non-endometrioid variants. You're going to hear about them next year in the 4th course. So now we're going to focus only to the endometrioid variant of the adenocarcinoma. What is the predisposing factor to that variant? The ones that we've mentioned already. This is the hyperplasia of the endometrium. Especially the so-called atypic hyperplasia has an increased risk to turn malignant, to turn into an adenocarcinoma. Usually affects perimenopausal women around the menopause, and usually affects obese women because they have an increased estrogen production. And that tumor really proliferates and invades, driven by the estrogen stimulation, the hyperplasia of the endometrium and the tumor. What is the main clinical presentation of that tumor, of adenocarcinoma uteri? Those are the irregular uterine bleedings. This is what leads that woman to the doctor. And how does the tumor looks grossly? It could even either look like whitish, plaque-like tumor mass that invades the wall of the uterus, or it can look like exophytic tumor mass that fills up the lumen of the uterus. So it could be either have either endophytic growth invading deeply the wall of the uterus, or most exophytic growth with tumor masses filling the uterine cavities. About the metastasis, again, like in the case of the stomach adenocarcinoma, here we can have lymphogenous metastasis to the regional lymph nodes in the pelvis, in the pelvic lymph nodes, or we can have hematogenous metastasis, where the uterus doesn't drain through vena porte. So where should we expect the metastasis? Where is the most common place for the metastasis?
Lungs?
Lungs, yes. Lungs, bone, those are typical places for the hematogenous metastasis. Okay, so we'll continue with the second part of the malignant epithelial tumors. Now again, it's your turn to recognize the organ.
Kidney.
It's a kidney, yes. Because we see glomeruli, the round structures, we see tubules. So this is kidney. We keep looking at the slide and we come to that area where the structure is destroyed from that solid proliferation of tumor cells. This is your slide, carcinoma rennis. The only slide with that you have from kidney with the malignant disease, carcinoma rennis. This is actually the most common malignant neoplasm of the kidney. And another name is clear cell renal cell carcinoma. This is how you're going to find it in the books. Why clear cell? because the cytoplasm of the cells look empty, looks white. This is due to accumulation of lipids and glycogen that has been extracted, removed during the preparation of the slide. That's why clear cell, renal cell carcinoma. What should you know about that tumor? It has a really typical gross appearance. It is a tumor mass with a variated cut surface. We see more yellowish, more yellow-orange areas that correspond to the tumor cells. We see more reddish areas that correspond to the hemorrhages. You see those red hemorrhages here within the tumor. And we also see more grayish areas that correspond to necrosis. Here we see some cystic spaces. So a variated gross appearance of the tumor with different color depending on if we're looking at tumor tissue, necrosis, or hemorrhages. About the histology, besides those clear cells, what else should you mention? That tumor has only a little stroma. You see that the parenchymal cells, they prevail, and we almost don't see any stroma. This is another typical feature about that tumor. What about the metastatic potential of the renal cell carcinoma? Maybe you've read in your books that most of the malignant epithelial tumors tend to give lymphogenous metastasis. This is an exception from that rule because the renal cell carcinoma really has a tendency to give hematogenous metastasis. It really likes to grow into the renal veins, and it can form tumor masses that proceed from the renal vein into the vena cava inferior, and they can reach even the right side of the heart and shower the lungs with tumor emboli. So the metastases within the lungs are really typical for the renal cell carcinoma. So this is one of the exceptions from the rule that malignant epithelial tumors like to give lymphogenous metastasis. We've also seen metastasis into the brain from renal cell carcinoma. So hematogenous route of spread is preferred for that tumor. What is the major clinical presentation of the tumor?
Loss of weight.
Okay, it could be loss of
pain.
Okay, pain, lumbar pain, loss of weight, but this is with the advanced tumors later in the course, and the pain.
Cachexia.
Okay, yes, again with most advanced tumors. But something that is present at the beginning, one of the earliest signs, is hematuria, painless hematuria. Okay. So these are the most important things that you should know about the renal cell carcinoma. We move to the next malignant epithelial tumors. again, we should recognize the organ here.
Liver.
It's a liver, yes. Mhm. It's a liver because it's a solid organ because we see those liver plates, we see the central vein here in the middle of that field. And then we keep looking into the slide. And we'll choose an area where to start from. Well, maybe here. Here we have an area with trabecular pattern, with trabecular growth. But those trabeculars of hepatocytes are really thick, more than 2 cells thick. We don't see the normal arrangement of the lobules. We don't see central veins. We don't see portal spaces. So the structure here is destroyed. So our guess is that we're dealing with hepatocellular carcinoma. Here we reach another area with more solid growth of tumor cells with more light appearing cytoplasm and nuclei that are really large and they just pop up. They come to our attention. This is the cellular pleomorphism. And if we keep looking, we may find even an areas with a greater nuclear pleomorphism. Look at those big nuclei. It is really different in size, in shape. They have large nucleoli. So this could be nothing else than malignant tumor of the liver, hepatocellular carcinoma in this case. Actually, the hepatocellular carcinoma may have different growth patterns. It may have trabecular growth like the first one that we've seen. It may have a solid tumor growth like here in that area. It may have a clear cell features like in that area here. So the hepatocellular carcinoma has more than 10 histologic variants that really makes the diagnosis difficult if we look only at the metastasis and we don't know that there is a primary liver mass. Here it's easy because we recognized a normal liver tissue, so we know we are dealing with a tumor of the liver. But when we're looking only at the metastasis, it's really difficult. Then to make a diagnosis, we should use immunohistochemistry in order to prove that this is hepatocellular carcinoma. What should you know about that tumor? What is the predisposing condition in more than 80% of those patients for hepatocellular carcinoma?
Cirrhosis.
This is a cirrhosis.
Yes.
Mm-hmm. Yes, cirrhosis, either from hepatitis B or C. This could be alcohol-induced cirrhosis. It could be due to metabolic diseases of the liver. Only less than 20% of the cases we don't see background cirrhosis. But again, we can find hepatitis B or C infection, but without cirrhosis. So in most of the cases, we are having predisposing condition. Do you know what serum marker is increased in the case of hepatocellular carcinoma?
Is
This is one oncoprotein that is produced by the tumor cells.
P53 protein.
No, this
Alpha
Alpha-fetoprotein.
Alpha-fetoprotein, yes, you're right. Alpha-fetoprotein is increased. It's non-specific, okay, because it can be increased in many other liver diseases. But when it's over 1,000, when we measure it in the serum and it's over 1,000, it strongly speaks about liver cell carcinoma. And we use it mostly for follow-up of the patient to see when there is recurrence after the patient has been treated with hepatocellular carcinoma. Okay. About the gross view of the tumor of the hepatocellular carcinoma, how can we see it grossly in the liver? It could be either one solid dominant tumor mass. We could see multiple nodules in different places of the liver. This is the so-called multinodular tumor, or the third gross form is the diffusely infiltrative that looks exactly like a cirrhosis. Many small nodules that are sprinkled all over the liver, and it's undistinguishable from the cirrhosis. This is the diffusely infiltrated form. So 3 gross forms. And as we've mentioned, many histologic forms or pictures. What about the metastatic potential of that tumor? It can give either lymphogenous metastasis in the regional lymph nodes at portum hepatis, or just like the renal cell carcinoma, this is another exception that likes to give hematogenous metastasis using vena hepatice. Through the hepatic veins, they go into the inferior vena cava and then into the lungs. So that tumor can give not only intra-organ metastasis in different parts of the liver, but also can give metastasis to the lungs using the hematogenous route. Okay, we move to the next malignant tumor, malignant epithelial tumor. Again, it's your turn to recognize the organ.
Testicles?
Yes, this is testis. Here in the upper part of the field, that thick pink solid tissue is tunica albuginea. And underneath, we see all those seminiferous tubules that gives us our organ diagnosis. So we're dealing with testis. Actually, you have only one slide from testis. So if you recognize that this is testis, you're done with your diagnosis. And that slide is seminoma testis. Now we should look and find that seminoma. Okay, and here we reach to an area that is different from everything else. So before we start explaining the histologic view of seminoma, first let's mention what type of tumor is that. This is actually one of the so-called germ cell tumors. And it usually represents more than 50% of all germ cell tumors. Do you know any predisposing conditions for that tumor? Cryptorchidism?
Yeah, the undescended
Yes,
testis.
undescended testis or cryptorchidism. It's a major one that predisposes to seminoma. It usually affects young men, about 30 years of age. What is the macroscopic, the gross view of that tumor? When we cut the testis, we see a whitish solid tumor mass within the testis, which is the most common picture of the classic pure seminoma. Why do I say pure? Because in some of the cases, the seminoma can be mixed with other germ cell tumors. That could be either yolk sac tumor, that could be teratoma or choriocarcinoma. And then the prognosis is different because those other components, they tend to give hematogenous metastasis, and they should be treated differently. And actually, they pose a worse prognosis than in the patients with pure seminoma. So when we cut that tumor in the grossing room, and if we see areas with hemorrhages, with necrosis, we already know that we might be dealing with mixed germ cell tumors, not the pure seminoma. Otherwise, as we said, the pure seminoma looks white, solid tumor. In the testis. And what do we find histologically? The main feature about the cells is the clear view of the cytoplasm. Okay, here we see the tumor cells, and you see that there is a clear space, like empty space around the nuclei of the tumor cells. Again, because the tumor cells, they accumulate lipids and glycogen, like in the case of renal cell carcinoma. But unlike the renal cell carcinoma, that tumor has a well-defined stroma. Here you can see that stroma invaded by many lymphocytes. This is another tip for seminoma, not only the light appearing empty cytoplasm, but also that well-defined stroma invaded by T lymphocytes. That is not typical for the renal cell carcinoma. here you can appreciate better the nests of the tumor cells with the light cytoplasm and the stroma with the lymphocytic infiltrate. And that nested pattern is typical for all the malignant epithelial tumors. What about the metastatic potential of seminoma? Where do we expect to see the metastasis? It likes to give mainly and first in the course a lymphogenous metastasis via the lymphogenous route in the para-aortic lymphatics, para-aortic lymph nodes. So many of the students say, okay, the regional lymph nodes are the inguinal, but for the seminoma, they are not. Seminoma is trying to send the first lymphogenous metastasis higher up around the aorta, in the lymph nodes around the aorta, the so-called para-aortic lymphatic chains. Maybe because this is the place where started the descendants of the testes and the metastases are trying to go back home. This is how you're going to remember that. And late in the course, in the more aggressive tumors only, we can see hematogenous metastasis to the lungs. So every patient with seminoma should be checked with a CT scan for lymphogenous metastasis around the aorta and for masses within the lungs, metastatic masses within the lungs. Okay, this is about seminoma testis, the most common germ cell tumor of the testis. Again, clear cells, like in the case of renal cell carcinoma, but this time the organ is testis, and we have well-defined stroma infiltrated by lymphocytes here. We move to the next malignant epithelial tumor. It is called choriocarcinoma. You have already heard that choriocarcinoma is another type of germ cell tumor that can affect not only the testes, but also the ovary. Because germ cell tumors we may have not only in the testes, but also in the ovaries. What should you know about choriocarcinoma? It's really an aggressive tumor that is widely metastatic. It gives its metastasis directly within the blood using the hematogenous route. Every organ can be affected. It can give metastasis to the lung, to the liver, to the brain. And one specific metastasis is into the vagina in women. Because choriocarcinoma arises from the trophoblastic element that give rise to the placenta. Actually, like the normal placenta, those tumor cells are in direct contact with the blood. They don't have their own stroma. They directly contact with the blood. And here you can see how all those large tumor cells with pink cytoplasm directly contact the blood. They don't have their own stroma. That's why it's so widely metastasizing and aggressive, that tumor. So when you talk about that tumor, you should mention the two main cell types that compose the choriocarcinoma. I will just find a better place to show you those two types of tumor cells. Okay, we can use that field here. So what are those two types of tumor cells? The multinucleated ones are called syncytial trophoblasts. Here you see a couple of them on the right. There are some in the center, one in the upper field at 12 o'clock. All those multinucleated with dark nuclei tumor cells and with ample pink cytoplasm are syncytial trophoblasts. The other ones that have more light, pale cytoplasm and just one nucleus are called cytotrophoblasts. So you should just know that there are two types of tumor cells and to describe what is the difference between both of them. Syncytial trophoblasts are larger cells with multiple nuclei and large, ample pink cytoplasm. The cytotrophoblasts have light, pale cytoplasm and only one central nucleus. Those are the two main types of cells that compose the parenchyma of that tumor. And again, there is no stroma because that tumor directly contacts with the blood, as you can see, and gives a wide metastasis. It's really aggressive. We can see it not only in the ovary, but also in the testes as part of other germ cell tumors. Most of the time, the pure choriocarcinomas are really rare. They present only 1% of all germ cell tumors. They're usually mixed with some other type of germ cell tumors, either seminoma or yolk sac tumor or teratoma or embryonal carcinoma, but rarely they're pure tumors. They're treated by chemotherapy and they really can melt away once that chemotherapy is started. So they are aggressive, but they really are at least at first controlled by that chemotherapy. Okay, and we reach to the last malignant epithelial tumor for today. Again, the initial organ diagnosis will be yours. Although here the small amount of the parenchyma of the organ is left. What does it look like? Those spaces filled with the pink material.
Thyroid gland?
Yes, it's a thyroid gland. We see that colloid that fills some of the left follicles here. But we also see a lot of lymphoid tissue. All those bluish zones here are lymphoid infiltrates with pale germinal centers. This is not normal for the thyroid gland because thyroid gland it's not a lymphatic organ. And when we see such lymphoid follicles within the thyroid gland, we think about what disease? One of the most common autoimmune diseases of the thyroid gland.
Hashimoto.
This is Hashimoto thyroiditis, or your slide from the first semester, struma lymphomatose. So Hashimoto thyroiditis slightly increases the risk for the most common carcinoma of the thyroid gland. This is the papillary carcinoma of the thyroid gland. So your slide is called Carcinoma papillare glandule thyroidae. And here we're looking at that papillary carcinoma right now. We see some branching papillary structures, but they're not the only criteria for the diagnosis, because branching papillary structures we may have also in the hyperplasia of the thyroid. So we look further. We go to the higher magnification and see the nuclei that line those papillary structures. They're really typical for the diagnosis. So our main diagnostic criteria here is the appearance of the nuclei. As you can see, they look like they're one on the top of another. They're really tightly packed. This is called molding of the nuclei of the papillary thyroid carcinoma. And besides that molding, we see that is well delineated nuclear membrane and like a washed or almost empty center of the nucleus. This is the so-called Orphan Annie appearing nuclei, like the eyes of Orphan Annie, which was a cartoon character in New York, Orphan Annie. So the nuclei appear empty like the eyes of that Orphan Annie, hence the name of those nuclei. So all those changes are really typical, and they give us the diagnosis. When we see those nuclear changes, we are sure that we're dealing with papillary carcinoma of the thyroid gland. Not the papillary structures. They are not our defining feature. Although they give the name of that carcinoma. Again, a lower view of all those papillary features. And when we see them, we should check for the specific nuclear features in order to make the diagnosis. Okay, that carcinoma could be either a single nodule within the thyroid gland or could be a multifocal, even affecting both lobes of the thyroid gland. What about the metastatic potential? It doesn't really have a tendency to give distant metastasis using the hematogenous route. It's highly unusual for the classic papillary carcinoma of the thyroid gland, but it usually can give lymphogenous metastasis in the regional lymph nodes, the cervical lymph nodes. But if this is a single tumor nodule, a small tumor nodule, if this is a young patient, even if we have metastatic 1 or 2 cervical lymph nodes, that still implies a good prognosis. So the classic papillary carcinoma of the thyroid, it's not an aggressive tumor. It usually affects people in reproductive age, mostly 20 to 40 years of age, and it even may affect children. Actually, this is one of the most common malignant tumors of the thyroid gland in children, as in adults also. So this is that characteristic appearance of the papillary carcinoma of the thyroid gland. Some of the tumors, something really specific, is they have a specific type of calcifications called psammoma baris. Here we don't see them. But in some of the tumors, they could be present. They look like solid purple calcified bodies. They could be seen on the ultrasonographic images and on histology also. So they are really typical for some of the papillary carcinomas, psammoma bodies. You have another slide that you're going to look at from the tumors that also can have psammoma bodies, and this is meningioma. So when you reach to meningioma, just remember that the same calcifications, the same psammoma bodies, you can have also in the papillary carcinoma of the thyroid gland and also in the meningioma. Okay, if you have any questions, you can ask. So we'll stop here because we'll get through maybe 10 slides. So I think it's enough for today. And tomorrow you will continue with some other assistant for the rest of the epithelial tumors. This is breast carcinoma and possibly the mesenchymal tumors.
Will that be on a different link or will that be the same one?
If you'll be on the different what? I didn't hear.
Will that be on the same link to the meeting?
Oh, yes. It's going to be on the same.
Is it going to be the same time as well?
Yes. Mm-hmm. I think Dr. Topalov mentioned that at first when he started. So it's going to be again at 10 o'clock.
Okay.
Mm-hmm.
Okay, thank you, Professor.
Okay. You're welcome.
Thank you very much.
Thank you very much.
Thank you, Professor. Professor, is it possible to have the next meeting on Zoom?
Well, I'll ask Dr. Topalov. Maybe because
we can record it and you have a lot more control. You can use the arrows and things like that.
But the Zoom, you need the premium account to have like longer than 40
I don't know.
minutes.
I reckon the pathology department can stretch to the $15 it costs to get an account.
It's free.
Okay, I'll ask Dr. Topalov if he can arrange that. I think they didn't choose Zoom because it's not possible to be seen by 160 people because the first fraction is 160 people. Not that all of them are joined today, but I think that was the presumption of Dr. Topalov when he created that platform.
Maybe we could do some smaller groups.
Yeah, or if not, then what can happen is somebody can come in and sort of screen record from your end, because that would be much, much easier and the quality would be less dog shit. I mean, less bad.
Mm-hmm. We've tried with other platforms. We have
that's fine. But what I mean is that somebody could come in, or you guys could do it on your end, and you could record the screen. It would take like 5 minutes to set up. And then you could upload it to something like YouTube if hypothetically we were all very, very sleepy in the morning and couldn't be bothered to wake up at like 10.
Mm-hmm. Okay, I'll bring up that question in front of the others.
Thanks. Much appreciated.
Okay.
Thank you, Professor.
Okay, you're welcome.